So when everybody saw that, the ketogenic diet was working, there was already a lot of patients that were benefiting, and there was not so much risk. So I think we have a position now, like even in the community, that we are not part really of the traditional medical practice and the hospitals, but the clinic is seen as a reference clinic. So when patients don't know, or when doctors don't know exactly what to do with the patient, they send the patient to us.
Okay, good morning, everybody. Hope you guys can hear me. We have Dr. Carlos, and forgive me if I butcher the last name. It is Zumarraga. Is that welcome? Thank you.
Fantastic.
Thank you.
Hi, Dr. Baker. Nice to meet you.
Yeah, likewise. Now you're in Mexico, if I'm not mistaken. Is that correct?
Yes. The south part of Mexico, Yucatan.
In the Yucatan Peninsula. Okay, so is that that's near Cancun? Is down in that area, right?
Yes, it's very close.
I'll be there in October.
Yeah.
So anyway, it's nice and hot down there. I've been there. I was there years and years ago when I was 16, so almost 40 years ago. So this was the last time I was there. So, well, if you don't mind, by way of background, can you introduce yourself? What specialty of medicine you're practicing? Tell us a little bit about your background, if you don't mind.
Yeah. So I practice nutritional medicine. I work in ketogenic diets. My work or my studies is in medicine. I'm a physician. So I've been doing the keto medicine for like 6 years. I've been treating patients with keto medicine for 6 years. So I'm graduated in 2006 here in Mexico. I went to the US. I did the test, the ECFNG, and I did a little bit of research in some of the universities in the States, mainly in the University of Pittsburgh, that is in Pennsylvania. So I was involved in transplant surgery, in liver transplant, and it was fascinating for me. It's a great experience to be there. So after like some time there, like 6 years after being in the United States, I decided to come back to Mexico. And I did a little bit of research in regeneration, regenerative medicine. So I was trying to focus on the liver and regenerating the liver after the experience in the States in liver transplant. So I did a little bit of treatments, experimental medicine in liver regeneration. But after some time, I decided that the best way to continue with my profession was to start treating patients with nutrition, because I saw that the benefit for the patient was much better. I mean, it was better to do this kind of therapy, and the patient has less risk when doing this therapy, and we have better results. So I started doing the carbohydrate restriction and applying the treatment for different conditions, but mainly for insulin resistance and for diabetes and fatty liver disease and polycystic ovarian. So the list continued to get larger and larger, and I have now a full practice using carbohydrate restriction for metabolic health.
Fascinating. Yeah, it's interesting coming from liver transplant. And I remember when I went through school, I mean, liver transplants were, and they still are, they were this enormous operations. They used to be extremely blood intensive. They would go through the whole blood bank. I think they've gotten better at blood management now and that hopefully. But when you were talking about liver regeneration, what was being used back then? I'm just kind of curious about, because we know the liver is a relatively plastic organ. It has a relative decent capacity to sort of regenerate relative to things like nerves and, cartilage and other tissues. But what was being employed to regenerate the liver? I'm just curious.
Yeah, the liver is a plastic organ. So when I didn't do the transplants myself in Pittsburgh, I was just helping in the surgeries, and I was mainly involved with donor surgery and with back tables. So back tables is what you try to fix, you fix the organ, so there is not much blood and all of that. So what we were doing really, maybe I I didn't focus exactly in my initial presentation, but I was focusing in pancreas, in pancreatic regeneration. But then after, studying type 2 diabetes and the role in type 2 diabetes, the problem is not the pancreatic failure, the problem is insulin resistance. So I saw the window to return to the therapy, to the liver problem, the fatty liver disease and the cirrhosis and then the liver failure. And I saw that there was the same mechanism. So the ketogenic diet can be used to stop the inflammation in the liver. And then when you stop the inflammation in the liver, and I think this is the mechanism for everything in regeneration, and that is possible today, is that you stop the damage, you stop the inflammation, and then you allow the organ to regenerate itself. The one that can do. I mean, for example, we know that when we do the ketogenic diet in diabetes, in type 2 diabetes, we can see an improvement in C-peptide and insulin, because there is no more glucolipotoxicity in the pancreas, and we see that there is a functional production of insulin in these organs. So we have less insulin resistance in the liver, we have more production of insulin in the pancreas, so we improve the condition in the patient. And in the liver, but I treat a lot of patients with fatty liver disease, and even with NASH, that is non-alcoholic steatohepatitis. And with the ketogenic diet, it reverses completely. So this is what I mean with regeneration.
Some people will, and I've seen many of the studies, particularly calorically restricted ketogenic diets are especially effective at reversing non-alcoholic fatty liver disease and NASH. Do you find that there has to be a caloric deficit or isocaloric? I mean, can you reverse fatty liver in a caloric surplus?
Yeah, I think this is a very difficult question, because we are confronting two models, the caloric model and the carbohydrate insulin model. So it's difficult. Right now there is two schools of thought there. But I think that we do need to have a caloric deficit, because we need to be in catabolism, we need to lose weight, we need to trigger lipolysis, so we need a little bit of caloric restriction. But we have metabolic advantages of the ketogenic diet by itself. So the carbohydrate restriction, it's fantastic to stop, for example, diabetes, the hyperglycemia in diabetes type 2. And you don't need a little bit as much weight loss in this context. But if you try to remove the fat from the viscera, then you need to have lipolysis. You need to remove fat. So you need to have a hypocaloric deficit. This is the way I see it. I'm not really a basic researcher. I'm more like a clinician. So that's what I see in the clinic, that we need the caloric deficit. But the caloric deficit happens when you're in a ketogenic diet, because you have like a spontaneous caloric deficit.
Yeah, I mean, there's a lot of thought around long-term satiety around ketogenic diets. You just don't eat as much. You don't need to eat as much. And for some people, that alone, that feature alone just makes all the difference for them. And that can be very helpful. You mentioned, diabetes and, fatty liver. I think you mentioned PCOS. We're seeing, I see within the community I'm in, which is sort of ketogenic. I mean, some people are, but we're certainly restricting carbohydrates here with this kind of meat-based diet. And I see gains in almost every single area of pathophysiology, whether it's mental health, cardiac disease, liver disease, metabolic disease, arthritis, so on and so forth. So, since you've been practicing in Mexico, and I imagine there's a lot of metabolic disease in Mexico. I mean, I've seen that quite a bit. How well received is your practice in Mexico? I mean, you sound like you're busy, so some people are going there. Is it still considered fringe and dangerous and scary, and no one wants to do it, or what's the thought down there?
I think it's accepted, because the way we do the therapy was mainly we didn't do a lot of advertising at the beginning, so it was like an organic way to grow. And the patients start coming and they start having results. Mainly in the beginning, what was very impressive in the patients was the decrease in triglycerides. So this was amazing, and there was something that everybody expected, that a high-fat diet would give you. I mean, everybody that don't know about the ketogenic diet or the carbohydrate restriction think that the fat that we eat, that you have an increase in triglycerides. So I started having patients with metabolic syndrome with very high triglycerides, and the triglycerides start coming down. So the public or the patients start talking about the ketogenic diet. So it was like a surprise for the medical community that this was happening. So when everybody saw that, the ketogenic diet was working, there was already a lot of patients that were benefiting, and there was not so much risk. So I think we have a position now, like even in the community, that we are not part really of the traditional medical practice and the hospitals, but the clinic is seen as a reference clinic. So when patients don't know, or when doctors don't know exactly what to do with the patient, they send the patient to us. So it has been accepted reluctantly, but I think that the drivers of the acceptance was the patients.
Yeah, and you mentioned you're not a researcher, you're a clinician, but at the end of the day, this is where the real world results happen on the clinical end, and we can't. When they talk about evidence-based medicine, you can look at the research and you can look at what actually happens on the ground, the clinical experience, and also you want to consider patient desires and wants in forming a plan. And I think that's a part of the equation. A lot of people leave out the patient's desires, and then also the clinical experience, which is very valuable in my view. So as far as you mentioned, you have a very good success rate with reversing disease or getting people off medications, I would assume. How hard is it to get people to do this diet? Because a lot of people say, well, I don't want to give up whatever carbohydrate. The cuisine in Mexico is a little different than here in the U.S. There's some traditional foods that people are probably very attached to. How do you sort of break that habit?
Yeah, usually when the patients come, they have they are kind of pre-selected in a way by themselves. So they know that when they come to the clinic, they will have to change. So sometimes the patients don't want to change forever. That's a problem, because if you are intolerant to carbohydrates, you have to be below your tolerance. So you have the remission or you continue with the benefits. So this is a constant struggle for the patients in the future. But at the beginning, when they want to do try the ketogenic diet, they can do it for a month or 2 months and they see the results immediately. So the way I do it is I don't try to change the patients a lot. What I do is I ask them, what is what you eat? And, this is the way you fix your plate to become ketogenic or low carbohydrate. If you are going, every restaurant in the world is keto, is a ketogenic restaurant, if you know what to choose from the menu. So I teach them with the traditional foods that they are eating, what can be part of the plate and what has to be eliminated completely. And I try to also to tell them that there is what is out from the diet, you cannot try a little bit. It's out of the diet. But what is in, you can eat it. So in that way, they don't come to the clinic, or they don't start the nutrition from zero. So they have the basics, and I just teach them how to do it. And it's very successful to do it that way, because I have patients, I'm sorry. I have patients that come from other states, that they have different cuisines also. Not very different, but different. And it's easy to do. They just, you teach them how to pick the protein and a little bit of, the leafy greens and a little bit of fish and these non-starchy vegetables. And that's it. It's pretty easy for the patients. The problem is the maintenance in the future.
I saw, and it may have been, I think it's been 2 years now, maybe 3 years, where I know either Mexico or one of the states within Mexico, maybe Chihuahua or something like that, they proposed not allowing kids to buy soft drinks and sodas. Was that a nationwide thing? Did it go through? Has it had an impact?
Yeah, I think there was a really strong push to remove all the soft drinks and even decrease the sugar, and they put labels in every product like this is too high in fat, this is too high in sweeteners, this is too high in carbohydrates. At the beginning, it worked. There was the idea to do it, but they didn't continue. I think there was something like something political there that stopped the progression of that program. But we still have the labels in the products here in Mexico. But the problem is that the labels are based on the dietary guidelines that we know that they are not good. So they, for example, demonize the saturated fat, and they don't talk too much about the carbohydrates. So it's something, but it's not perfect. I mean, for our model of therapy, that is, the carbohydrate insulin model and the low carbohydrate diet, it's not enough, and it's confusing. I mean, for the patients, it's not confusing because it's what they know. But if you're teaching somebody to do a low carbohydrate diet that they want to follow the levels, it's a disaster. So it's not really. The idea was good, but the implementation and the models are mixed up. So you cannot do much with that.
Are you doing any significant laboratory testing in your patients? Is there something you looked at for, say, metabolic health? And is that the same thing you look at for, say, cardiovascular prognosis?
I do a lot of testing. Almost every patient is tested. I do traditional testing with the normal labs that we have here in Mexico. So I do, like, for example, I do a lot of blood chemistries. I do kidney tests, liver tests. I do glucose. I do fasting insulin. I do C-peptides. I do ultrasounds for staging the liver, the fatty liver, the stage of the fatty liver. This is mainly the test that I also do ultrasound for polycystic ovarian syndrome, testosterone, free testosterone for the patients that have suspicion of polycystic ovarian syndrome. So I do the traditional things that are not very, special laboratory tests. Like, for example, I don't do the small test, the small particle LDL or anything like that, because we don't have that easily access to that technology. But yeah, I do a lot of testing, and so everything looks good objectively and subjectively. So the patients lose weight. The patients get better quality of life. They get satiety. The glucose start decreasing. The hemoglobin A1C start decreasing. The liver function tests start going down when you do the ketogenic diet. So there is a lot of clinical cases. I have like 2,000 patients already that have been studied with labs. Not like every patient I change, the labs. Sometimes I do it every month. Sometimes I do it every 6 months. So there is no like a standardization of the labs, but I have the labs from the patients.
Do you, what are your thoughts on protein? Are you restricting protein? Are they eating good amounts of protein? And what are those protein sources?
Yeah, the animal protein is, is the best biologically, evolutionary, everything that is related to human nutrition. So animal protein is the one that we use. We use eggs and seafood and fish and poultry and beef and pork. We are not scared about the saturated fat. But we have we try to consider protein. In the majority of the patients, we do it at limited. You eat as much as you want to satiety, and this is good for example, diabetes and almost every condition. But for some conditions, we need to calculate protein. Yeah, for example, for cancer patients, we try to decrease the amount of proteins to 1.2 grams per kilo, something like that. So we try not to give too much protein because of the glutamine theory. The glutamine can be a problem with the patients with cancer. So we try to decrease a little bit the protein in these patients. Yeah.
Well, I was just going to comment, 1.2 grams per kilogram is twice or 50% above the RDA. So it's still relatively higher than what the RDA would recommend as a minimum. So are you seeing any detrimental effect on renal function? Any kidney issues with people on these higher higher animal protein diets?
No, and I do 1.2, and sometimes I do 1.6. So it's not a low protein diet, but we try not to go more than 2 grams per kilo.
Yeah, so
that's our opinion. It's just theoretical.
Yeah,
so that's what we follow, and we don't see any problems with the kidney. If anything, we see improvements in kidney function because the majority of my patients have problems with diabetes. So if the problem is glucose and we reduce glucose and we increase a little bit protein and fat, the kidney function gets better. It doesn't get worse.
Yeah, that would mirror the experience of David Unwin in the UK. He's published a paper on the same thing with similar diet, low carb, animal protein, and saw reversal of chronic kidney disease, which I think it just makes sense to me, as far as, thinking that animal products are damaging our kidney, which doesn't make sense. What, you said the majority of your patients are diabetics. How successful are you at weaning them off medications? What kind of concerns do you have about, obviously if they're on insulin, I don't know, are they still using, I'm forgetting the class of drug. Anyway, what kind of issues do you have with weaning people off diabetic drugs?
Yeah, it depends on the patient. Usually when the patients are taking, the first thing that we have to do is to establish if the patient is pancreatic sufficient or not. Mm-hmm. That's the first thing. So if the patient is hyperinsulinemic, is type 2 diabetic, then there is no worry about the problem when removing medications. If the patient is suspicious to have pancreatic failure, then we have to study more and to check the C-peptide and insulin. If the patient has low insulin, low C-peptide, this patient is having pancreatic failure. So it's a different kind of patient. It's a type 1 diabetic. It's not any longer a type 2 diabetic. So mainly what we treat is type 2 diabetics. So in type 2 diabetics, we can remove medications. The first drugs that we remove are the flosins, the ones that decrease the elimination of sugar through the urine. Those are problematic because they can create one thing that is called normoglycemic ketoacidosis. Mm-hmm. So we remove those immediately. And then we remove also sulfonylureas, mm-hmm. that is like glipizide, and these medications increase the secretion of insulin because they create hypoglycemia. And with the insulins, we decrease the insulins in percentages. So sometimes we decrease 30%, sometimes we decrease 50% when we start the ketogenic diet. And it's very successful. I mean, not everybody goes, we stop insulin, but in the majority of the patients, we stop insulin. And usually the drug that we still use in the patients is metformin. Metformin is very good medication to combine with the ketogenic diet.
You mentioned, some of the type 2 diabetics go on to develop pancreatic failure. They stop secreting insulin to a significant degree. Their C-peptide falls. And you said you mainly treat the type 2 diabetics. What do you do with those people that have had pancreatic failure? Is there any utility for the ketogenic diet in that group?
Yeah, sometimes we find these patients because they come diagnosed as type 2 diabetics, but they are taking long-acting insulin and fast-acting insulin. So they are in a basal bolus regimen, but they are considered type 2 diabetics. And in these patients, we see they are thin. They come differently. They are not obese. They are thin, or they at least are not super obese. And what we do with these patients is, if the patient is a type 1 diabetic, what I do in reality is I check the patient and I see the experience that the patient has managing diabetes himself. If he has understanding of the diabetic medication and he knows how to manage the rapid insulin, and I can teach them how to decrease the carbohydrate load and how to decrease the insulin. So I have done that, but I have to make sure that the patient is experiencing the condition that he has. If the patient doesn't have experience or doesn't have good understanding of what is happening with her body or with his body, I don't enroll the patient in the ketogenic diet for the moment, because a lot of these things depends on the patient.
Yeah, makes sense. I mean, could you get into trouble with that if they overdose on insulin and they end up putting themselves in a hypoglycemic coma. That would be that would certainly be a problem. Are you seeing any sort of, I mean, if somebody's got waning pancreatic activity, say relative borderline low C-peptide, do you put them on a ketogenic diet? Do you ever see that recover? Have you seen that recover at all?
Yes, I have seen it, but just in the C-peptide production. So we see increase in C-peptide a little bit. For example, from less than 1 to 1.2, something like that. Mm-hmm. We have seen an increase in C-peptide in patients that are type 2 diabetics, that they are developing pancreatic failure, but they are still sufficient to tolerate a ketogenic diet, because the amount of insulin that the patient needs to tolerate a ketogenic diet is not much. So you only have to control ketones and control protein with insulin. So if the patient has borderline pancreatic function, they can do the ketogenic diet. And we see that they tolerate the ketogenic diet. They tolerate the reduction of medications. And we see increase in the production of C-peptide and insulin in the patient. But I have documented this case only one time.
Have you, you mentioned, you mentioned cancer about, 1.2 grams per kilogram. So I assume you're seeing some cancer patients then. How are you managing cancer patients? Are you managing them with a ketogenic diet, and what have been the outcomes of that thus far? Yeah.
Yes, I'm managing a little bit. It's not my main practice. I have some patients with cancer, mainly patients that have metastatic cancer, that is disseminated cancer. And they are doing well with the ketogenic diet. Some patients combine the ketogenic diet with chemotherapy, and it makes better. I mean, the patients get better results. And one of the most important things that we do with the ketogenic diet is that we try to decrease the side effects of the chemotherapy. So this is the first thing, because when the patient is in ketosis, the cells are protected from the chemotherapy a little bit. This is what basic research says, and is what we see in the clinic also. So they have less vomiting, for example, less nausea, less vomiting. They feel stronger in the post-chemo, in the days post-chemo. They recover faster from the chemo. So this is everything that is good. But there is another aspect of the ketogenic diet, that it weakens the cancer cells. So if you have the cancer cells are weakened by the lack of energy that you are creating with the ketogenic diet, and then you give the chemotherapy, you hope to have more killing of the tumor. And this is what we have seen in a limited amount of patients, but with PET-CTs, we see that there is less, almost remission in the PET-CT with the chemo and the ketogenic diet. And we also, I mean, I didn't do it, but the team of the oncologists, they did also the immunotherapy. So they did immunotherapy, they did chemotherapy, and I did the ketogenic diet in the context of the therapy, and the patients do very well with that.
Yeah, anecdotally, I've also seen a number of people that have gone through chemo and they've been on, low carb carnivore diets. And they say that they tolerated the chemotherapy extremely well. In fact, their oncologists were very surprised that they had almost no side effects at all, which, again, it's not a good situation, but it can make that certainly better. Do you see any utility for diet on mental health? Are you seeing depression, anxiety, things like that improve with diet changes?
Yes, I think there is an improvement in mental health in the patients. I haven't studied, it's not really clear from the clinical point of view that there is an improvement, because I haven't treated patients like a very, very sick in the mental health, like, for example, schizophrenia patients. I haven't studied really the schizophrenia, for example, or bipolar disorder or anything like that. But there is an improvement. What I can tell you of the mental health is that the patients that have a lot of problems trying to do a diet, because they have a lot of anxiety or they have a lot of obsessions about food obsessions and all of that. When you do the ketogenic diet, you have decrease the cravings in the patient, and the patients feel more capable of doing the diet. So it makes the diet, or to do the diet, more easy. And from the mental health aspects, I cannot tell you clearly that there is an improvement, but I can imagine that there is, but I haven't seen it like clinically really, like really clearly. I haven't seen it in the patients.
Is there a different difference? Obviously, you mentioned PCOS, but I mean, are you finding any different approaches for the diet or the therapy in general between men and women that you do this with?
Yeah, not really. The patients that I usually start the patient with 20 grams to 25 grams of carbohydrates a day, and the diet is exactly the same in that context, in that way for everybody. So everybody has results, but there is different in the results because men have better results and faster results. But that's because the men, we have a different hormonal profile. So we lose weight faster than women. So women it's more difficult to do the weight loss and the metabolic repair, but it's also because of the hormones. So there is difference, but it's not from the diet; it's from the biology of the patient.
Yeah, well, I mean, certainly a lot of women would agree with you as they sometimes struggle with that, and it seems like unfair that some men just start and immediately lose weight, and some women don't. It's not always the case, but certainly has been. Do you see? My understanding is, in IBS or irritable bowel syndrome is fairly prevalent in Mexico. I think I read somewhere it was significantly high compared to even other countries like even us. Do you see a lot of that IBS, and does diet seem to have a role on that?
Yeah, I see a lot of problems with colic and irritable bowel syndrome. There's a lot of patients with that. Usually the patients come with IBS, but they have other conditions, so they come from the other conditions and they have IBS, and the IBS gets better immediately. I mean, this is something that we see immediately, and this is because we have a reduction in the plant base. So the lower we go in plants, the better in these patients. And I have had a patient that is not the same, but is related with Crohn's disease. Mm-hmm. So, and this patient, I put him almost in a very, very low carbohydrate diet, maybe 5 grams, 10 grams of carbohydrates a day. He improved a lot. So it was a male patient, so he improved a lot in the condition. And so even the medications, the immunosuppressant could be reduced in the patient. So we see a lot of improvements in the colon. We see a lot of improvements in the stomach. We see decreasing gastritis, for example, immediately in a week of the therapy. And we see also improving gastroesophageal reflux disease. And this is all related, I think, to the plant content of the diet.
Yeah, I see that very frequently with people on a carnivore diet. Inflammatory bowel disease is very well suited to this diet, and then reflux seems to be related to how much gas the diet produces. And a plant diet is going to certainly do more of that. Do you, as far as what about your personal diet? Is this something you've adopted as well? Is this something that, most physicians that practice a ketogenic diet do it themselves. So was there a reason you want to do that?
Sure. I started the diet maybe 2016, and I started by myself, the diet. The first time I did it was in myself. So I lost maybe 35 kilos with the diet, and I stayed that way. But what happened is that I did the ketogenic diet. I lose I weighed 110 kilos, and then I lose weight to 76 kilos. That was my lowest weight as an adult. And then I stay in the ketogenic diet, but I start increasing a little bit carbohydrates, not much, but I started eating nuts, for example, and peanuts, this kind of things. A little bit, not much. And during the years, because it was not dramatic the way I increased weight, but I increased to 84 kilos, so from 76 to 84 kilos in a ketogenic diet plus a little bit of nuts. So recently we start talking about, I'm working with Lipedema Simplified. We are treating patients with lipedema with the ketogenic diet, and with CarnivoreDiet we start kind of a pilot program for patients that want to do the carnivore diet, and it's working very well. But I also reduced my carbohydrates to zero, practically a carnivore diet for the last maybe 2 months or month and a half. And I have lost from the 84 kilos, I'm weighing now 80 kilos again. And the good thing, I'm not hungry, I have no cravings. So I feel really like the first time I did the ketogenic diet. This is the way I feel right now. But I'm now in a carnivore diet, basically.
Interesting. How hard is that to do in Mexico? Just out of curiosity, you have any trouble with that? Finding meat, and is it
finding meat?
Yeah, is it difficult to find meat in Mexico? Is it pretty easy?
Yes, it is. So there is we are in our cuisine, like the Yucatan cuisine is compared to the Chinese cuisine, like in variety, and we have a lot of type of foods and all that. But almost everything is based on pork and poultry here in Mexico. Mm-hmm. So we don't eat a lot of beef, but I like beef. I eat beef, but it's something that we don't do it like at home. Usually when you want to eat meat, like a beef or a steak or ribeye, whatever, you go to a restaurant and have a ribeye or something. So I mainly eat pork, and sometimes during the week I eat beef when I go out. Yeah. It's not difficult to find it. It's very easy.
So what is a good local dish, carnivore dish that you can get in the Yucatan Peninsula? So I'll keep that in mind when I visit there later this year.
Yeah, you have to order the dish fixed, like we say, but the one that is very traditional here in Yucatan is one that is called pokchuk. Pokchuk is a Mayan word. So we are from the Mayan culture is here, and the pyramids and all of that. So we have like a mix of Spanish and our Spanish is influenced by the Mayan language. So pokchuk is like a pork grill with tomato and onion, a little bit of tomato and onion and salt. That's it. And sometimes they come with beans, but we have to remove the beans. Mm-hmm. And it comes with tortillas, that is like corn. Mm-hmm. We remove that also. So it's the way we teach the patients. But the pokchuk is good. It's a good dish.
Interesting. It sounds pretty interesting. Do you, as far as your implementation, are you doing it by yourself? Do you have somebody that helps to coaching or nutritionist, or how do you do this?
Yeah, no, I'm the only practitioner in my clinic. About the conversation that we have about the acceptance of the diet, the acceptance is not a problem for the patient, but for the community of doctors, it's difficult to accept. So we are like an island. We are a closed system in a way. We are like a private research center in a way. So the good thing about the practice of ketogenic or lifestyle ketogenic diet is that we can be a little bit close in the way we practice because we control everything. So if we do a good selection of the patient and we go do a good therapy, the patient can be in our system. I mean, it can be managed in the ketogenic way of eating. So I have interactions with the hospitals and the clinics, but it's not really much. So yeah.
How do you? I mean, obviously the main criticism to higher fat diets, and particularly ones that have animal protein and saturated fat in them, are going to be heart disease. Elevations in LDL cholesterol, which not infrequently occur. How do you manage that? What are your thoughts around that? What are your thoughts about cardiovascular risk and ketogenic and low carb diets in general?
Yeah, that's something that happens. I explain the patient always what they call that maybe the LDL cholesterol can go up, but the LDL cholesterol that will go up is the one that is good because we have different, like the large LDL is the one that will go up. So the cardiovascular risk can be assessed in two ways. You can assess your cardiovascular risk with your LDL and your total cholesterol, or you can assess your cardiovascular risk with metabolic syndrome. So the ketogenic diet will reverse the metabolic syndrome. That is the visceral obesity, the high blood pressure, the diabetes or pre-diabetes or hyperinsulinemia. The triglycerides will go down. the HDL will go up. So we reduce the cardiovascular risk by reducing the metabolic syndrome, and we reduce, the idea is that we are reducing vascular damage. So if we reduce vascular damage, then we reduce the process of atherosclerosis. So LDL is not really a strong risk factor for cardiovascular disease. And if the patient is insulin resistant and they are coming to the clinic because they have a disease that is coming from the insulin resistance, then the best way is to reduce or to reverse the disease with a low carbohydrate diet.
Do you, I mean, I know you said you came from kind of maybe a research background in the University of Pittsburgh. Yeah. Are you interested, or have you looked at doing any research on your current patient population, publishing some studies? Is that something you have thought about?
Yes, I've been putting all my data in paper, really. I don't, because I want to have everything. So the documents I have here is like the patients, the patients with the charts. So I have a lot of information from the patients, and I would love to do the research, but I don't have a lot of experience publishing, and so it's difficult to focus on research when really my work, my economic work, is to do the clinical therapy in patients.
Yeah, no, I get it. It's hard. It can be a lot of work for sure. Just, knowing what the sort of the background rates and incidence of cardiovascular disease in a local population in Mexico or in the Yucatan Peninsula, do you find that your patients have more or less or the same amount of cardiovascular disease? Do you have a feel for that?
Yes, I don't have, I haven't had problems with with vascular disease or the increasing in the rate of vascular disease in the patients. But the patients come with damage. I mean, many patients come and they have already damaged the arteries. And it's difficult to assess if we are reversing the disease because we don't do like ultrasounds, like carotid ultrasounds. We don't do, coronary calcium scores. I did it in myself, the coronary calcium score. I had 0 after 2 years of doing the ketogenic diet, but I'm young. I have a history of insulin resistance, but I still, I'm not in that age that we can see the damage already present there. But the patients don't come with heart attacks or anything like that when we do the ketogenic diet, and everything gets better and they get less inflamed. So one thing that is very, very important, I think, is that the overall inflammation in the patient goes down dramatically. So the patients feel better, they can move better, they can decrease the amount of medications, they increase the laboratory, so they decrease the triglycerides. So it's, I'm not worried really about what we are doing with the patients that have insulin resistance because it's clearly beneficial for them and for the cardiovascular disease risk.
Do you see, you mentioned they move better. Are you seeing improvements in things like arthritis? Does that seem to improve as well?
Yes, in the autoimmune diseases like Crohn's disease, we see improvements there. The lower the carbohydrate, the better. We see also improvements in rheumatoid arthritis. I have 3 patients with lupus. In lupus, what we have seen is that there is a reduction in the progression of the disease and the kidney disease. The lupus nephritis, that we call it, is like, it's better. The profile is better. The patients lose weight and everything. So lupus, we treat rheumatoid arthritis, we see improvement in pain and in motion. We see improvements in osteoarthritis a lot. I have patients that have been able to walk again because we have the decrease in the weight in the patient, but we also because we have anti-inflammatory effects of the diet. So sometimes the anti-inflammatory effects of the diet, you can see them in 2 weeks of the therapy before the weight loss has been significant. And other diseases with autoimmune component, maybe uveitis. I have patients with uveitis that they have improved, but this disease is episodic, so you don't really know exactly if it's happening because of the diet or not. But we think it is happening because of the diet. So there is an improvement in inflammation, but there is 2 types of inflammation: the general inflammation and the specific inflammation. In general inflammation, we see improvement, definitely. In a specific inflammation or autoimmune inflammation, we see improvement, but we don't know how much.
Yeah. How, and again, I'm not sure how big of the community that you practice in, if it's even small town, big town. Do you run into your patients out and about in the community? How much do you enjoy your practice? A lot of doctors are burnt out and tired, and they get frustrated. I mean, what has it been like for you practicing this way? Is it something you really enjoy?
Yeah, I really enjoyed it. I mean, practicing this kind of medicine is very enjoyable because I never practice in a different way because it's the way that my curiosity led me. I never wanted to settle. I always wanted to, to look for, understanding and never stop understanding what's happening. So in reality, I never practiced like traditional medicine because when I finished school here in Mexico, I went to the States and I was with the professors and, Miami, and I went to Pittsburgh. There was also experience and everything was new. So when I came back, I didn't practice traditional medicine and I did a little bit of the regenerative medicine research. And then I switched to the therapy, the low carbohydrate ketogenic diet, because it's the way the process led me to do it. So I never was like a traditional doctor. And the way I practice today, it's enjoyable. But I don't know any other form of practicing because I didn't do anything before that.
Yeah, there's a lot of physicians out there that don't practice in this way. In fact, most of them don't, and many of them are just frustrated and burn out with that. Is there any? You'd mentioned the patient community understands and gets it and is benefiting from this, but you said the local other physicians are they're not bought in. Is there a community of physicians or healthcare providers in Mexico that is there a low carb community among folks in there, and have you been able to convert any of your colleagues?
Yeah, this is happening. We have a lot of today, keto, it's everywhere. The keto word is everywhere. But the keto, like clinical keto, is not something that you find easily. It's difficult to find because there is a lot of factors to be considered and the patient evaluation and all that. So there is a lot of people that is doing the ketogenic diet, but they do the diet as a diet. So they don't consider the individuality of the patient. And this is kind of dangerous in a way because you don't know what you are doing with the patient. Like we were talking about the pancreatic failure and the context of the patient and the medications of the patient and all of that. And sometimes the ketogenic diet is wild. It can be given by anyone. So this kind of is a problematic for the patients because they don't know where to find information. But there is a lot of people that is trying to do the therapy. But this, I think, is confusing a little bit the patients and maybe harming a little bit the evidence-based therapy. But people that has background in medicine, or they are doctors, they are looking at the therapy. For example, I have a patient with type 1 diabetic, and I start doing the carbohydrate restriction. We decrease the insulin, we decrease the long-acting insulin, we decrease the fasting insulin, the rapid insulin, the bolus insulin. And the patient told me, the doctor, my endocrinologist, want to know more about what we are doing because before I came here, my glucose was 500s all the time. And I have lows and highs and lows and highs. And now I'm not perfect, but I'm controlled. I have a range that I can manage and I feel at ease. I can live. I can have tranquility. I can have a house. I can know what is happening when I don't eat correctly. So he wants to know more. Can you give me the nutrients that you give me, the list of nutrients and how to calculate carbohydrates from the meals? And I said, yeah, sure. You can have it. This is, if you eat meat, it's 0 grams. If you eat a little bit of greens, it's 5 grams. And then your program is around 20 to 25. And this is your base, is the floor. You will work with this. And then when you have the floor, then you can manage your therapy and you will be more successful. So there is a lot of people that is asking questions, and I think it's growing, but it's a little bit chaotic in a way.
Well, it's good to hear it's growing for sure. Do you, So for your one of the concerns of physicians, well, maybe not physicians, but maybe hospital administrators, is that if you put people on a ketogenic diet and they come off their medications and they're healthy, they don't need the doctor anymore. Are you having a lot of patients that you just never have to see them again, or do you keep in contact once a year? How does that work?
Yeah, it depends, because the patients usually our clinic is like it's a paid clinic, so it's not something that we can enroll the patient for years and years because they have to come to us. But usually after 3 consults, the patients know and they can manage the program. I mean, they already, in a way, they are free from the system in a way. If they need something else, they call me and they come back. But in 2 consults, they already know what to do and how to manage the problem. And there is a lot of patients. We have the system that is like the governmental system, and many patients are enrolled in that system. Like it's called the Social Security, Mexican Social Security, or there are 3 of them, no? And they get medications every month or every 2 months. And many of my patients, they have their bags of medications that are not used after they do the therapy. And they pick up the medication from the institution because they have to go to pick it up. And they take the medication to centers for people that are sick, that are not, it's like not for profit. And it's happening a lot. So they come with their bags full of medication and say, okay, I'm going to take this one. I will still take metformin, for example. I will still take, I don't know, levothyroxine. And then I'll take this all my bag to the nonprofit center.
That's one thing I wanted to ask, and we're getting close on time, but what about thyroid? A lot of people are concerned that low carbohydrates will result in thyroid failure. Is that something you see, or what are your thoughts around thyroid function?
Yeah. From the diet, there is really no problem with the thyroid. I mean, if you do the ketogenic diet, the idea is that because we decrease insulin, we liberate energy. So the system has energy. So there is no suffering, in a way to say it. There's no suffering inside the system because you're getting your calories from your fat and your nutrients. So there is no problem in that way. If you do a high carbohydrate diet and you have high insulin, then your fat stores are difficult to access. So you get problems with the energy inside the system because you are not eating enough. You don't have the liberation of fat. So there is theoretically a problem with the amount of energy that the cells are using. And this can create metabolic, that your metabolism slows down. But patients come with thyroid disease. They come already with thyroid disease. So we don't see many changes with the ketogenic diet in thyroid disease. The patients keep the levothyroxine or the hormone replacement that they are using. I don't change the dose there. I don't increase the dose. So I just follow up symptoms. If the patient start having symptoms of hyperthyroidism, because theoretically, if we are reducing the inflammation, for example, Hashimoto's, we are reducing inflammation in the thyroid, and then the medication can become strong. And the way that we will notice that is with hyperthyroid symptoms. So I kind of think about that when I see the patient that is taking the levothyroxine. If I have a suspicion that the medication is too strong, then I do the thyroid, TSH and T3 and that. And the patient is too high, then I decrease the thyroid. But this is not something that I do often. Maybe I have done it twice in all my patients. And this is not common.
Yeah, I've seen some reference to thyroid sensitivity, and just like insulin sensitivity, we have thyroid sensitivity that may improve with low carbohydrate diets. Carlos, thank you so much. We are out of time, unfortunately. Can you tell us where to find you, either on social media or if somebody wanted to be one of your patients in Mexico, how would they do that?
Sure. You can find me in Facebook, I think would be easier. The clinic is called Clinica Keto. So you just type Clinica Keto and you will find, the clinic. And I have there the information and, the phone number and everything else. And yeah, sure. We do, sometimes we do consultations in telemedicine. Not usually, but sometimes we do it. And mainly we see patients here in the clinic. So you are very welcome to contact us, and we'll be happy to help.
And the clinic is, what city is it in? Just for those.
It's in Merida, Yucatan.
Okay.
Yeah.
Carlos, thank you so much for visiting with us, but also thank you for doing what you're doing with your patients. I'm sure you're saving a lot of lives or improving the quality of lives and doing medicine how I think it should be done, where we actually focus on the disease rather than the symptoms. So thank you so much. You guys, the rest of you guys, have a great day.
Thank you very much.
Yeah, sure.
Okay. It's a pleasure. I appreciate it a lot.
Sure.
It's an honor.
Thank you. Okay, guys. We'll see everybody tomorrow. Take care, guys. Bye-bye.